Agora eu vou convidar a pesquisadora Luan Swart. Ela é pesquisadora do Institute for Social and Health Sciences da Universidade da África do Sul. Tem mestrado em psicologia e é doutoranda da Universidade da África do Sul. Dentre os temas de suas pesquisas estão violência física e sexual entre adolescentes, vigilância aos maus-tratos e visitação domiciliar para a prevenção de maus-tratos infantis em comunidades de baixa renda. So, you have 30 minutes. And I will let you know.
Okay, I'm going to look at the strategies for increasing effectiveness of home visitation programs on a more broader level. An effective intervention program is able to demonstrate intended effects on the outcomes. Home visiting is a popular method for delivering a range of family services aimed at altering parenting practice with long-term goals of improving children's development and well-being. However, the evidence has been inconsistent regarding their effectiveness, and this has led to research looking at those programs that have been the most successful and that have identified certain key elements of an effective program. I'm going to be looking at this. These effective elements cover 3 areas: the design, implementation, and evaluation of a program. Okay, most of these studies, though, do reflect on high-income countries, and there's a lot less information on low to middle-income countries. So I want to include our experience as well in implementing a home visitation program and how we managed in terms of these strategies. Our program was intended to reduce household hazards for children, to prevent childhood injuries among children 10 years and younger in low-income neighborhoods, and we used paraprofessionals as home visitors. The results from this randomized control study indicated that the intervention was effective in reducing hazards for burn-related injuries and poisoning. However, we didn't have any success with the fall-related injuries. Okay, in terms of the design of the program, there are 3 things. Effective home visiting programs must have clearly specified, applicable, and realistic goals. A well-defined program protocol and curriculum with a clear theoretical framework linking the interventions to the desired outcome, as well as a specified target population. Most of these strategies you have heard in the preceding presentations that have been done. Okay, the first one, goals of the home visiting program, clearly specified and applicable and realistic. By applicable, that it is based on epidemiological research and it does reflect the community needs. In South Africa, childhood injuries are a big problem. Amongst older children, these are attributed to pedestrian-related traffic incidents and falls, whereas younger children from 0 to 5, injuries arise from burns, poisoning, and most of these occur in and around the home. Okay, whereas burns and poisoning are amongst the main causes of all South African childhood fatalities, falls are the leading causes of non-fatal injuries. Evidence also suggests that these injuries are related to poverty and they are concentrated in low-income neighborhoods marked by a lack of infrastructure and resources. Okay, the goals also need to be realistic in terms of what the organization can manage. We are only a research institute, so therefore we developed the program and looked at the other institutes that could help us in terms of experts with regard to child injury prevention, as well as community members and a statistician to help us with evaluating this program. Okay, also the second one in terms of design is that the program must be a well-defined program protocol and curriculum with a clear theoretical framework linking the interventions to the desired outcomes. With injury prevention, talk about the 3 E's, education, enforcement, and engineering. that these are the most important to effect change. We try to build this into our home visitation program, and also that the alliance between the visitor and the caregiver would encourage the parent to take up the safety practices. We had to develop a new curriculum for our context. So, as I said, we relied on the experts in the field, Child Accident Prevention Foundation of Southern Africa, as well as emergency services. They helped us develop this curriculum. The actual intervention consisted of 4 visits. The first visit focused on child development and injury risks, the second, the prevention of burns, then poisoning and falls. During each visit, the home visitor was required to provide the caregiver with information about the injury prevention practices, to use photographs or flip charts to stimulate discussion, and also to complete a hazard checklist with the parent, and then to discuss how to correct those safety hazards. They were also given a safety device. For example, with the poisoning intervention, they were given paraffin, safety cap for paraffin containers, as well as demonstrations on how to use the safety device. And then at the end of the intervention, parents, home visitors spoke to parents, and if there were any other problems, they referred them to the relevant service providers in the community. Each household was also supplied with a community referral directory. The caseload per visitor was an average of 10 households, with 3 weeks to complete the visits for each topic, and visits lasted between 20 and 60 minutes. Okay, in terms of, also with design, you need to have a specified target group. This needs to be consistent with the goals of the home visiting program, as well as the curriculum and interventions to be employed. This, in hindsight, this is where we could have done better. We targeted mothers of households in low-income areas with children 10 years and younger. But the main injuries to children 5 to 10 were the falls, and that is where our program didn't succeed. But in terms of the younger children from 0 to 5, we had positive results for poisoning and burns. So therefore, if we had just focused on children 0 to 5, our program could have been more effective. Okay, the second part is looking at the implementation of home visiting services. If programs are not implemented well enough, this can affect program effectiveness. So ongoing monitoring of the implementation process is essential, and the key aspects here are client participation, which we've just heard about, and also the selection, training, and support of home visitors, as well as consistent delivery of the curricula. Client participation, well, in terms of low family engagement and high attrition, these seem to be particular challenges within the home visiting field. Although this may be hard to control, some of it does relate to aspects of design. With our experience, we didn't have any real problems with client participation. And I think most of this was due to the fact that the organization already had a presence in the community. Also, the home visitors were from the community itself, and the interventions were very limited. It was only 4 visits. And also the visits were scheduled to accommodate the parents. If they were employed, the home visitors would make appointments during the evenings or the weekends. Okay, the selection, training, and support of home visitors. This, for us, was the difficult. We had to put a lot more energy and work into this area. Home visitors must possess the required knowledge and skills to deliver the interventions effectively, and the skills to establish a relationship of trust with the client. Although in the literature much of the debate has been about whether you should use professional or paraprofessional workers, this will depend on your program goals, and also in areas where expertise is scarce, we made use of paraprofessionals. they offer a cost-effective strategy, and also that they are from the same community, so it should be easier for them to build trust with the client as well as deliver the intervention in a culturally sensitive manner. Okay, the training. Home visitors must be well trained in the goals and methodologies of the program in order to be effective. We also had to develop a new training curriculum. And because this was a new training curriculum, we had to evaluate it so that we knew that the home visitors could actually deliver the program before the intervention started. We spent a lot of time on this. What we eventually came up with was doing individualized, standardized role-playing sessions or simulated clients where they could demonstrate their knowledge and skills and competencies in ways that simulated real home visiting situations. We actually built up a house. The target population, the houses are small, they are shacks, and they usually consist of one room, so it was easy to build that up with the various risks inside the house. This method, the simulated client method, has been used by other to train nurses, social workers, and it offers a way to assess competence in a planned and structured way. It allows control of the choice of problems so that the assessment can be directly linked to the learning objectives and allows the problem to be presented consistently for every trainee. Okay, this provided us with very, very valuable information. From the start, we saw that the home visitors were not sufficiently trained, and we had to redesign the whole training program. And we also realized that our home visiting curriculum was not detailed enough. So before we actually went out into the field, we were able to correct those. And interesting enough, looking at we measured the demographic characteristics of the trainees as well as their outcomes of the training course. And the training outcomes were related to education level as well as qualities of warmth and enthusiasm, which consistently comes up in the literature. Staff turnover, that is another challenge noted in the literature, and is something that we experience too. This, of course, can affect the outcomes of the program. There's difficulty in having a regular training agenda. Every time a home visitor leaves and you employ a new one, it means more training. And also it affects the relationship that they have with the client. Most of the reasons for our home visitors leaving was that they found permanent employment. Although we did pay them for the visits, this was only for the 3-month period. So when permanent employment came along, that was a much better alternative for them. So that is something we would have to consider, but I think it is the nature. If someone has permanent employment, then they need to take that. We also had a look at staff turnover and what personal qualities were related to those that left. And we found that qualities such as trust and preference for teamwork was related to those home visitors that stayed on for the program. In terms of staff turnover too, supervision is essential. This can help them deal with the stress of the program as well to ensure that they deliver the program as it is intended to be delivered. The consistent curriculum delivery, which I just spoke about. Although with training you can't tell exactly what is happening out there in the field, so we need to find ways, innovative ways to actually see what is happening in the home visit, the black box, as was spoken about earlier, and ways of doing that. Same things mentioned, videotaping, the supervisor visiting with the home visitor, and diary keeping was another way that we help manage to see what was happening. And then we also had focus groups with the parents afterwards, as well as the home visitors, so that they could give feedback on the experience. Interestingly, and this also goes to the attrition, the families were very happy with the service. It was the home visitors, especially from the one site, that had a problem with the program. So for us, the difficulty was really working with the home visitors, seeing that they were supervised, seeing that they were that their needs were met, and we had to invest a lot into that. The final part of an effective strategies to improve their effectiveness looks at the adequacy of the evaluations. Here, the important parts are to measure the right outcomes, to employ the appropriate measures to detect the program benefits, and to design studies sensitive enough to detect positive effects that are being produced. This is a complex task that requires the input of a specialist in research design. Okay. These were the two sites where we implemented the program. Slovo Park near Johannesburg and Mzamo. They're both informal settlements. That means that they are shacks built out of wood and corrugated iron. Slovo Park has no electricity, inadequate recreation space within the home, lack of demarcations between cooking areas and sleeping areas, lack of safe storage, and in the community, unemployment, poverty, overcrowding, crime and violence is high. Nomzamo is much the same, except it is a transitional community in that it's moving from informal housing to permanent structures. Okay, our measures, we took a while, well, not a while, it was difficult. We actually wanted to measure injury outcome, but the program was not long enough to actually detect differences in injury. So we had to look at the injury hazards within the home instead. So that also means the measures it's important to measure the right outcome if you want your program to be effective. So looking at injuries, we need to have a longer term measurement. Our outcome measures with the presence of home hazards were scores for burn, paraffin appliances, as well as burns electrical, poisoning, and falls. Okay, it's also important to employ appropriate measures to detect program benefits. Well, there are well-known measures and that are reliable and valid in other work, but in the work that we had, there were some measures in high income context, but the risks were different. So we also then needed to develop an instrument to measure the household hazards. We had to pilot this instrument, looking for internal consistency and reliability, but we also found it was an important experience because we found items that had no room for improvement. For example, if houses were already safe, matches were kept or locked away from the children, we couldn't improve that. So then the program would not be effective. So we had to look for things that were a risk where there was scope for improvement. Also, not all of the electrical appliances included in our questionnaire were used by the households. And we also found that we didn't have enough information in our questionnaire on the risks of using paraffin appliances. So we had to go back and redesign our instrument to measure the outcomes. And also what we have found was that our original format wasn't working as well, so we had to redo that. Our research design, we used a cluster randomized control design, which included pre- and post-test assessment components. We used a cluster design to limit the potential of contamination of neighbors talking to their neighbors about the program. So the home was the unit of analysis, and we used 200 homes in the intervention and the control groups. And the data collectors allocated the random to blocks. We drew all the blocks up within the communities, and then they were randomized. And the data collectors had to interview the main caregiver in the household, obtain informed consent for participation, and implement the injury risk assessment. The outcome data was obtained 2 weeks after the final visit. Even after this preparation, we still had a few study limitations. Our study turned out to be slightly underpowered. also that we use self-report measures, although to some extent we did have a bit of observation in terms of the data collector had to go around and see with the checklist what the hazards were in the house. And also we did not measure the effect on injury occurrence. We looked at hazards instead. Another limitation was that the study period was very short, 3 to 4 months. So that also meant that we missed seasonal variation. For example, this was during spring and summer, whereas in the winter months, the burn injuries or hazards were more prevalent. In conclusion, I want to quote Combi that research demonstrates that planning and implementing effective home visiting programs is not a simple task. It requires careful consideration and fine-tuning with respect to the community to be served and the goals to be obtained. It also requires collaboration and consultation with a number of experts and community stakeholders, as well as the development of networks that are occurring here and in the United States to share information on strategies. This would help us in South Africa, where home visitation is new at the moment, when we have limited experience in low to middle income countries, and it is participation in seminars and workshops like this that will help us. So I thank you for the invitation, and I thank you for listening.